For the treatment, COPD in acute exacerbation. The primary goal of treating COPD is to increase the patient's life expectancy and quality of life while decreasing the number of COPD exacerbation and hospital visits. So let's define the delivering of oxygenation and tracheostomy care.
Delivering of oxygenation. The transport of oxygen is fundamental to aerobic respiration. Global oxygenation delivery or oxygen dispatch describe the total amount of oxygen delivered to the tissue each minute and is a product of the cardiac output and arterial oxygen content.
Delivering of oxygenation, purpose of care, maintain targeted SpO2 or saturation levels through the provision of supplemental oxygen in a safe and effective way. Relieve hypoxemia and maintain adequate oxygenation of tissues and vital organs. Give oxygen therapy in a way which prevents excessive carbon dioxide accumulation. Reduce the work of breathing. Efficient and economical use of oxygen, ensure adequate clearance of secretions and limit the adverse events of hypothermia and insensible water loss.
For delivering of oxygenation, the equipments needed are nasal prongs, simple face mask, non-rebreather mask, the venturi mask, and the bag valve mask.
First, check and verify the doctor's order. Second, perform hand hygiene and apply face shield and gloves if indicated. Third, adjust bed to appropriate height, lowered side rails, and check locks on bed wheel. Fourth, attach oxygen delivery device to oxygen tubing attached to humidified oxygen source adjusted to prescribed flow rate. Fifth, applied oxygen device. Letter A, place tips of cannula into patient nares, loop tubing over patient's ears, adjusted lanyard. Letter B, applied mask over patient's mouth and nose, brought straps overhead. Sixth, maintain sufficient slacks on oxygen tubing and secure to patient's clots. 7th, observe for proper function of oxygen delivery device. 8th, verified setting on flow meter and oxygen source for proper setup and prescribed flow rate. 9. Check cannula or mask every 8 hours, kept humidification container filled at all times. 10. Posted oxygen in use, signs as needed. And lastly, dispose of gloves properly and perform hand hygiene.
Alright, so we'll start with the first low flow oxygen device, which is nasal cannula. A standard nasal cannula can deliver 1 to 6 liters of oxygen. And we'll talk about that shortly, what that kind of converts to in the amount of oxygen they're actually inspiring, or their fraction of inspired oxygen, or FiO2. So standard cannula, nothing really special about this. First of all, it will plug in the flow meter, and that's fairly simple. You have to have a Christmas tree, as we showed before. Plugs in right here. I always start the oxygen flow, turn the knob counterclockwise, and let's go with 3 liters here. The ball is at right in the middle of 3 liters. Now I'll show you how to apply it to the patient's face. Alright, so now I'm going to apply this to the patient's face. You're going to notice that there is a little bit of a curvature to these cannula prongs, as you can see it. What you want to think about are these going in and following the path of the nasal cavity. The nasal cavity does not go up, it goes back and around. So these things always curve back like this. If you put them on backwards like this, it's going to oxygenate the epithelial cells on the inside of their nose, but not get down into their oral pharynx, down to the lungs where you really need. So curving back, I always put it in the nose first, a little bit of pressure. Of course, I'm going to put it around this ear, and then I'm going to show you for this side how it goes over the ear and under the chin, and then this piece right here kind of goes tight. You don't want to go too tight with it, just enough to secure it. And then sometimes I do a little bit of adjustment to what feels best for the patient. One real key, don't do it too tight. A lot of the tubing is now made so that it's soft, because this can cause a lot of breakdown, hospital-acquired pressure ulcers, especially on the tops of the ears. And then if it's real tight across the skin right here, of course the skin's very thin, and then right under the nose if this is pulled really tight and it's not frequently moved. So this is how a nasal cannula is run, of course. It's going to go back into the nasal cavity, and it's going to act almost like a reservoir, so when they take their breath in, they'll pull that fraction of inspired oxygen down to their lungs, and then they exhale and take the next breath in. So this is a standard nasal cannula review, 1 to 6 liters. If the patient is on greater than 3 liters, we recommend humidifier, or what we call a bubbler. And what that does, it just helps to humidify the air so it doesn't dry out their nasal mucosa. Alright, so I'm going to talk about the simple masks now. So simple mask is a device we see it a lot in our post-surgery area. It's a nice way to deliver some oxygen. Also, I've seen it in labor rooms. They give it to a laboring mother if needs some oxygen. She doesn't like nasal cannula. It's a nice way to deliver oxygen, but it's a very poor way to give an exact amount of oxygen. So we're just going to throw some oxygen at this patient. You know, maybe their saturation will come up, maybe they'll feel a little bit better. But with this device, as you see, it's a mask, has a little adapter on it, it all comes together. It's going to deliver anywhere from like 40 to 60%. Now that's a broad range. So it's nothing that we're going to use when we're going to be weaning oxygen or anything like that. So generically, you can put a low flow of oxygen on this if you want, but usually it's recommended. We usually go anywhere from usually 8 to 10 liters. So I'll plug this in, go to 8 liters, and you can hear it running. This is what you'll see in some of those other areas. They're just delivering oxygen. The patients aren't necessarily critical, but we're just going to kind of deliver oxygen. Obviously, it goes over the back of the head here, and this part squeezes down on the nose, and we can give the patient oxygen. So one thing to note with this, you notice there's also holes in this part of the mask and in this part of the mask right here. In case this flow would be shut off and no longer come into the mask will fog up, so you'll know something happened. Plus you can hear the flow meter running back here. But then the patient will still be able to breathe. This isn't sealed to the face like a CPAP mask, so they'll still be able to breathe, but it will be uncomfortable after about 30 seconds to a minute. So it's just one thing to kind of look out for. So that's the simple mask. You won't see a lot of those around, but just in case you do, kind of a generic oxygen device. The big boy that we see the most often, of course, used in EMS world, ER, and any place where a patient's getting ready to crash, is the non-rebreather. So what this is all about is they are going to, for one, non-rebreathe their CO2, but what they're going to do is they're going to pull 100% oxygen each breath from this. So this device, we call it 100% that we're delivering. In all honesty, it's more like 80 to 90. It's really hard to deliver 100% unless you have an endotracheal tube in somebody or you have a CPAP mask still on their face. So the thing with a non-rebreather, let me unplug it here real quick. It'll come like this. You'll see the little bag hanging off of it. That means it's not ready to go. Don't put this on a patient with the bag deflated, because usually what happens is when they take a breath, there's a one-way valve in here and they're pulling air from, guess what? Nothing that's in the bag. So you'll see the bag deflated on it. So one thing you always want to see, if you walk in a room, let's say for rapid response, you see someone on a non-rebreather, you should always see this bag inflated. It's like an RT's pet peeve. On a non-rebreather, there's only 1 liter flow that goes on this. 15 liters or even higher. See what happened to the bag? It blew up. And in that bag right there, that is 100% oxygen. You'll also see somebody stick their hand in here and put their hand over this thing, over that valve. It will blow that up even more. It fills it faster when you need it. So when it goes on the patient, it looks a little bit like this. And you'll see the bag inflated like this, and this is what it should sound like. When they take their breath, you'll actually notice this bag will deflate a little bit, and then it will fill up while they're exhaling. not while they're exhaling into it because it's a one-way valve. But what'll happen is the oxygen from the flow meter will refill it. So each time they take a breath, it comes from this bag and delivers really close to 100% FiO2. Now you walk in the room and you see your patient on an unrebreather, and this happens a lot unfortunately, and somebody just put on 3 liters and you look and that thing's deflated, you'll know that something's up. For one, you're not delivering much FiO2 at all. And then for 2, this is kind of a fun thing, you know, if you're watching soaps with your non-medical partner and you're like, the cool thing about the soap operas is this is where you can always catch them on being non-authentic, because every time they put somebody on non-rebreather on the soaps, it's always deflated. So if they would ever want to consult a respiratory therapist or a nurse, they would just have some external air piped in to make this more realistic by having this inflated. So in real life, this is always inflated. It looks a little bit like this. And then you'll notice some little pieces of diaphragm that might be covering up these holes. What that does, it actually increases the FiO2 that you're delivering to your patient. Remember, a non-rebreather is temporary. You can leave them on this for a while, but they're going to need something else, either ventilatory support or non-invasive ventilatory support, because this is a high amount of FiO2 that you're delivering with a non-rebreather. So in transport's great, not for long periods of time.
Tracheostomy care definition. A tracheostomy is a surgically created opening in the trachea. A tracheostomy tube is placed in the incision to secure an airway and to prevent it from closing. Tracheostomy care is generally done every 8 hours and involves cleaning around the incision as well as replacing the inner cannula of that tracheostomy tube. After the site heals, the entire tracheostomy tube is replaced 1 or twice per week depending on the physician's order.
Tracheostomy care to maintain airway patency by removing mucus and unencrusted secretions, to maintain cleanliness and prevent infection at the tracheostomy site, to facilitate healing and prevent skin excoriation around the tracheostomy incisions, to promote comfort, to prevent displacement.
For the tracheostomy care, the equipments needed are first, in tracheostomy kit, which includes the cannula ties and obturator, the next size smaller, the pre-cut clean gauze, the syringe with feeding tube, the gauze for wound care, scissors, saline nebules, and water-soluble lubricant. Next is the tracheostomy cleaning supplies, which includes the saline soak swabs, saline nebules, wet and dry face cloth, gauze pads, and the cap to soak the swabs in saline. For the additional tracheostomy equipment and supplies, we have the good light source, the sterile water and the container, the manual resuscitation bag kit, the towel for positioning, the oximeter, the suction machine, catheters and the tubing, the oxygen if needed.
For the procedures, check and verify the doctor's order, applied PPE as necessary, adjusted bed to appropriate height, lowered side rail, check locks on bed wheel. Pre-oxygenated patients for 30 seconds, ask patient to take 5 to 6 deep breaths, sanction tracheostomy, remove soiled dressing, discarded in glove with coiled catheter, perform hand hygiene, prepare equipment on bedside table. Open sterile kit and 2 gauze packages, poured saline on 1, open cotton swab packages, poured saline on 1, did not recap saline. Open sterile tracheostomy dressing package, unwrap sterile basin, poured proper amount of saline into it. Open sterile brush package, place in basin, prepared fixation device, prepared length of toilet tape, cut ends diagonally, laid aside to dry. Open commercially prepared package according to manufacturer's directions.
Letter F. Open inner cannula package if appropriate. Next procedure, applied sterile glove, kept dominant hand sterile throughout procedure. Then remove oxygen source if present, and then provide care of tracheostomy with reusable inner cannula. Letter A. Unlock and remove inner cannula while touching only outer aspect of the tube, and drop inner cannula into normal saline basin. Letter B. Replace tracheostomy collar, T-tube, or ventilator oxygen source over outer cannula. C. Use a small brush to remove secretions inside and outside inner cannula. Letter D. Held inner cannula over basin, rinse with saline, and use non-dominant hand to pour. Letter E. Remove oxygen source, replace inner cannula, secured locking mechanism, reapplied ventilator after hyperoxygenating if needed. And then, provide care of tracheostomy with disposable inner cannula. Letter A. Remove new cannula from packaging. B. Withdraw inner cannula while touching only the outer aspect of the tube, replace and lock new cannula. C. Dispose of contaminated cannula in appropriate receptacle, reconnected ventilator or oxygen supply. Next procedure, cleaned exposed outer cannula surfaces and stoma under faceplate properly with wet cotton and gauze. And then, use dry gauze to pat skin and cannula surfaces dry. Next procedure, secured tracheostomy. Letter A. Use tracheostomy tie method. 1. Instructed assistant to apply clean glove and hold tube in place, cut old ties. 2. Inserted one end of tie through faceplate eyelet and pulled ends even. 3. Slid ends of tie behind head, inserted ties through proper eyelets. 4. Pulled snugly. 5. Tied ends properly, allowed proper amount of space within tie. Lastly, inserted fresh dressing under clean ties and faceplate.
Tracheostomy care procedures. B. Use tracheostomy tube holder method. 1. Instructed assistant to apply clean gloves and hold tube in place or left TT holder in place until new device is secure. 2. Align strap under patient's neck. Ensured Velcro attachment were properly placed. 3. Place narrow end of tie under through face plate eyelets. Pulled ends even, secured with Velcro. 4. Verify the space under neck strap. Perform oral care with toothbrush or oral swabs and chlorhexidine rinse. Position patient comfortably. Assess respiratory status. Ensured oxygen of humidification delivery sources were in place and set at correct levels. Remove gloves and PPE discarded appropriately. Perform hand hygiene. Replace cap on normal saline bottles. Stored reusable liquids. Dated container. Stored unused supply appropriately.
Before providing tracheostomy care, ensure privacy, perform hand hygiene. Gather your supplies and introduce yourself to the patient.
Good morning. My name's Erin. I'll be the nurse taking care of you today.
Then identify her using 2 identifiers.
Can you go ahead and tell me your full name and date of birth?
Carolyn Lance, 3672.
Begin your care by clipping a pulse oximeter to the patient's index finger. Either hand is fine. If oxygen delivery is needed, be sure that the sources and humidification are in place and have been set to the correct levels. Arrange your equipment on the overbed table. Open the package for the tracheostomy tube holder according to the manufacturer's instructions. If your patient has a disposable inner cannula, open that package now. Then open a tracheostomy care kit, which contains 4x4 gauze, cotton-tipped applicators, dressing, cleansing brush, drape, and a suction catheter. Pour 1/2 inch to 1 inch of normal saline solution into the sterile basin. Don't recap the bottle of saline. Now hyperoxygenate the patient by adjusting the ventilator settings or by increasing the oxygen rate. Apply sterile gloves for suctioning. Remember, you'll need to keep your dominant hand sterile throughout the suctioning procedure. A patient with a tracheostomy sometimes has excessive peristomal secretions. To look for such secretions, apply clean gloves and a face shield if needed. Examine the tracheostomy site for soiled or damp dressings. Then suction the tracheostomy carefully to remove mucus. Before you take off your gloves, remove the soiled tracheostomy dressing and coil the suction catheter in your palm. Discard them inside your glove.
I'm going to go ahead and take out your inner cannula.
To care for a patient whose tracheostomy has a disposable inner cannula, withdraw the used inner cannula, touching it only on the outside. Quickly inspect the cannula for secretions and dispose of it. Then place the new inner cannula and lock it into position.
Okay, I'm going to put a clean one in.
If necessary, reconnect the patient to the ventilator or other oxygen source.
I'm going to clean out your inner cannula.
If the patient's tracheostomy has a non-disposable inner cannula, use your non-dominant hand to unlock and remove it. Use strict aseptic technique. Touch only the outside of the cannula and drop it into the basin of normal saline. If necessary, replace the oxygen source over the outer cannula. Pick up the inner cannula and use the sterile brush to remove secretions from it, both inside and outside. Then rinse it with normal saline. Replace the inner cannula and re-engage the locking mechanism. If necessary, reattach the oxygen source and hyperoxygenate the patient. Note that tracheostomies may lock in different ways. Some must be squeezed to release and reattach. While others are secured by twisting into position.
I'm going to clean around the tracheostomy site and change the dressing.
With either type of cannula, remove the drainage sponge and use normal saline to clean the exposed surface of the outer cannula. Then clean the stoma. Begin at the inner edge and move outward in circles, covering a 2 to 4 inch margin around the stoma. Be sure to include the area under the faceplate. Pat dry the skin and exposed outer surfaces of the cannula. Apply a new drainage sponge.
Are you okay?
To secure the tracheostomy using the tube holder method, you may want an assistant to hold the tracheostomy tube as you work. If an assistant is not available, leave the old tracheostomy tube holder in place until the new device is secure. Align the strap under the patient's neck. The Velcro attachments should be positioned on either side of the tracheostomy tube. Then place the narrow end of each tie under and through the eyelets on the faceplate and secure the Velcro closures.
Does that feel okay?
Yeah.
Okay.
I'm going to check your tracheostomy ties.
Verify that the neck strap has only enough slack for 2 fingers to fit snugly beneath it, or for 1 to fit loosely.
Does that feel okay? Are you comfortable?
When you've finished providing tracheostomy care, position the patient comfortably. Remove and discard your gloves and face shield if used.
There we go.
Replace the cap on the bottle of saline. Date the container and store it and any other reusable liquid. Finally, perform hand hygiene and document your care.